Good morning. This is Effie Battis from the Southern New York Association and Audacia Foundation. We will begin momentarily. I would like someone to just in the chat box let me know that everyone can hear me. Great. Okay, thank you all. We will begin momentarily. All right, wonderful, good, everyone can hear, good, great, okay. So we want to start right away. Good morning all, and welcome to the Southern New York Association and Audacia Foundation conference call to review COVID-19 infection control and prevention for nursing homes. COVID-19 has created unprecedented events with tremendous impact for the long-term care sector. And the information and guidance continues to evolve as the circumstances do. Today, we will take you through the latest information available from the CDC and DOH. Our objectives are to educate and support you and your staff during these tremendously unusual and difficult times. Support for this call and development of the materials is provided in combination by the New York City Department of Health and Mental Hygiene and the New York State Department of Health MLTC workforce funding. Before we begin, please note, all phones will be on mute as there are hundreds of participants on the line. We also ask that no one click on, there's a little red video button, and that instantly puts you on video. And I'm sure as some of you are working from home, we're not certain that you want all of your colleagues to see you in your pajamas, little morning humor. So we ask please that if you're accessing from your phone, if you click that start video button, it will allow us to see you as you are right now. So it's very important for those of us that aren't familiar to Zoom. The working from home, we realize is a very big adjustment for many of us. So that's why we give you a little bit of that guidance. So please, no need to press the start video button. We will control the slides from our end. If there are questions during, what we are requesting is that you can post your questions. There is, so the last button, if you're accessing on your phone where it says more, you can chat, you can post a question to the host if you would like a private question asked, or you can post a question to the whole group, and we will review all of that as we go through the presentation. So let's get started because there's a lot of information to cover, so many changes. There were changes even that came out this morning. There is a checklist that CDC and Department of Health developed together. We'll be sending that out after this call. It really will be, we believe, just a reframing of what was discussed today. And so with that, I would like to introduce the two esteemed speakers today, experts in the field of long-term care. We have Leah Matthias with us, who has tremendous experience, many, many years, has a bio too long to get into now, but many of you know Leah very well. We also have Carmentina Silvestra Tan, who is an infection control expert, and she has provided guidance for this meeting. And so these two colleagues will take us through the presentation. Thank you, and looking forward to providing you all with all of this very relevant information. Okay, I'll turn it over to you, Leah.
Thank you, Effie. Thank you, Effie. Hello, everyone. So this is Leah and Carmentina, who helped me develop this PowerPoint, will be joining us later to help me answer some of your questions towards the end. So let's begin to review the objectives. One is certainly to review the CMS recommendation for what the healthcare personnel should know about COVID-19. And we are also reviewing the latest New York State and New York City DOH health advisory regarding COVID-19 cases in the nursing home. We also want to look at CMS Interim Infection Prevention and Control regarding recommendations for COVID-19, and including the review of hand hygiene, proper steps and sequencing of donning and doffing of the personal protective equipment. So what healthcare personnel should know? What is novel coronavirus, COVID-19? It is a new coronavirus that has not been previously identified. This virus is not the same as all the other coronaviruses that commonly circulate among humans and cause mild illness, like the common cold. So why is this disease being called coronavirus disease 2019? So COVID-19 started because the World Health Organization announced this official name for the disease that is causing the 2019 novel coronavirus outbreak, which was identified initially in Wuhan, China. The new name of this disease, COVID-19, meaning CO stands for corona, V stands for virus, and D for disease. So it's much easier to say COVID-19 than to pronounce the whole correct name of coronavirus disease 2019. So what is the source of this virus? Coronaviruses are largely a large family of viruses. Some cause illnesses in people, others such as canine and feline coronaviruses only infect animals. Rarely do these coronaviruses infect people. This coronavirus is suspected to have occurred for the virus that causes COVID-19. An example of these coronaviruses that infect people is the MERS, Middle East Respiratory Syndrome, and SARS, Severe Acute Respiratory Syndrome. These are the two examples of coronaviruses that originated from animals and then spread to people. There are certainly a lot of information as well as misinformation, and it's important to go to the source that is available in CDC situation summary, source and spread of the virus. How is COVID-19 spread? Well, we're learning as we go. There's much to learn about the newly emerged COVID-19, including how and how easily it spreads. Based on what we know about COVID-19 and what is known about all other coronaviruses, spread is thought to occur mostly from person to person via respiratory droplet. The droplets can land in someone's mouth, noses, eyes of people who are nearby, or possibly be inhaled in the lungs of those within close proximity. So what is close proximity? So the close contact for close proximity is within the approximate 6 feet of the patient with COVID-19. Close contact can also occur while having direct contact with infectious secretions from a patient with COVID-19. Those secretions include sputum, serum, blood, and respiratory droplet. So what are those symptoms of COVID-19? And I'm sure many of you already know. The major symptom is cough, fever, trouble breathing, pneumonia. There are additional symptoms such as sore throat that are common with COVID-19. CDC believes that at this time, the symptoms can appear between day 2 to day 14 after one is exposed to COVID-19. So how can we prevent and treat COVID-19? And this is the biggest challenge with this coronavirus, because currently there is no vaccine to prevent coronavirus disease. And there is currently an antiviral that's still being tested, an experimental antiviral that is being looked at. The best way to prevent illness is to avoid being exposed to this virus. Prevention is key. The everyday preventive actions some of us are already performing includes avoiding close contact, avoiding touching your eyes, nose, and mouth, not easily done, staying home when you're sick, covering your cough or sneeze with a tissue, then throwing the tissue in the appropriate trash. Clean and disinfect frequently the high-touched areas. CDC does not recommend that people who are well wear face masks to protect themselves from respiratory diseases. And we'll talk about that a little bit more when we talk about PPE. Face masks should be used by people who show symptoms of COVID-19. So what do you do when you're sick? Stay home. Separate yourself or social distancing from other people. Call ahead before visiting your doctor. Wear a face mask to protect others. Cover your coughs and sneezes. Clean your hands. Avoid sharing personal household items. And cleaning high-touch areas of surfaces every day and as often as you can. Monitor your symptoms, self-monitoring. And when discontinuing home isolation, you need to consult with your healthcare provider or state and local health departments. So this is one of the latest health advisory relating to COVID-19 cases in nursing home. This was distributed and dated March 13. And let me drill down to some of the critical elements in this letter. The first item is to suspend all visitation. It was changed from restriction to suspension of all visitation except when medically necessary. So when is that? The exception is when providing support for imminent end-of-life situations and providing hospice care for our residents. So for nurses, this is already a flag that there's gotta be a care plan here to determine the end-of-life situations and the appropriate care being provided during that time. And a hospice care plan also needs to be initiated. And during this time, with this exception, the duration and the number of visits should be minimized. So there's a lot of education and reminder for the resident's family. The visitor must wear a face mask while in the facility and should only be allowed in the resident's room. The facilities must provide other methods to meet the social and emotional needs of these residents, because you're restricting them in their own private location or the resident rooms. Examples provided are certainly the video calls with family. For dementia residents, this is quite difficult, but we must use items, ways to keep their emotional needs and social needs in place at every day. An example would be the music and memory program using iPods to maintain their and meet their social and emotional needs. The facilities, of course, are doing this already. They're posting signage to notify the public upon entrance. What we need to support more is the proactive notification of residents and family members, especially those who visit frequently, to inform them of the policies and the suspension of visitations. Second is to immediately implement health checks for healthcare personnel or HCP and other facility staff at the beginning of each shift. And I know this is a difficult one because monitoring and someone needs to be assigned to provide that health check. This includes all personnel entering the facility, regardless of whether they are providing direct patient care. The facility staff performing health checks must wear face masks. Healthcare personnel and other facility staff with symptoms or with a temperature of 100.0 Fahrenheit should be sent home. And the healthcare staff and other facility staff who develop symptoms or fever while in the facility should immediately go home and be referred to seek medical care. So who is doing that in your facility? Who have you assigned to take this responsibility of monitoring and given the authority to send people home? All healthcare personnel and other facility staff shall wear a face mask within 6 feet of residents. This is because of the need for conserving PPE, which we'll talk about in a little while. These PPEs or face masks should be allowed for extended wear. Face masks should be changed when soiled, of course, or wet, or when the healthcare personnel go on breaks. The facility should bundle care and minimize the number of healthcare personnel or other staff who enter the rooms to reduce the number of personnel requiring face masks. What does bundle care mean? Bundle care is anticipating all that you need to get in the room of the resident and coordinate the care so that minimize the number of going in and out of that same room, minimizing the number of need of changing the face mask. That's one of the areas we can conserve the use of the face masks or what we call extended wear of face masks. Okay. All nursing homes must review and reinforce their policies and procedures. So all of the new regulations or upgrade, some are duplicative, but most are in sync about what the right thing to do is. But the policies and procedures need to meet standard and droplet and contact precautions and applicable for the care of all residents with their staff. Some of all of these hand hygiene practices we'll also review later in detail. What's important here is that we have to ensure that adequate supplies of hand hygiene materials, both alcohol, alcohol-based hand sanitizers or alcohol-based hand rub, and soap, water, and disposable paper towels are readily available. Daily Frequent cleaning and disinfection of commonly touched environmental surfaces, also called high-touch areas, must be done with EPA-registered hospital-grade disinfectant. Staff must be instructed on the need to follow all the manufacturer's instructions, including dwell times for cleaners and disinfectants. So we need to make sure there's dwell time as per manufacturer's instruction to allow the disinfectant to work to protect us from the virus. Let's talk a little bit just right now about N95 respirators. We know we have a general problem with the shortage. So the global supplies of some of the PPEs, including the surgical masks, have been impacted by COVID-19 outbreak response. And certainly part of the reason is the delivery of these supplies. So the New York State Department of Health asked nursing home administrators to encourage those staff who have chosen not to be vaccinated from the flu to consider being vaccinated as one of the ways to conserve the use of surgical masks. The regulation requires all staff not vaccinated against influenza for the current influenza season wear surgical masks while in the areas of patients. So if they're vaccinated, it might reduce the number of surgical masks being used for this purpose. In order to conserve PPE with regard to surgical procedure mask and N95, as an alternative to vaccination, where possible, nursing homes should consider assigning those unvaccinated staff to administrative duties that do not require them to interact with residents. Of course, this is limited in a way we could do this, but we could try to adjust if possible to redirect unvaccinated staff to perform other duties that do not require or minimize their requirement to interact with residents. Nursing homes should practice administrative controls on the availability of masks, realizing where we are in this shortage of face masks. This can be done by centrally holding and allocating masks to staff as necessary. But we need to balance this because we also need to make sure that, that these strict controls do not discourage the use of masks when indicated for patient care. So we have to maintain a balance of monitoring the use while making sure that the staff has adequate access and use for the face mask when indicated. The signage should also include visitors who require a face mask based on transmission-based precautions when they are visiting the resident. Any potentially contagious resident whose visitors are not restricted for visitation, and those are the end-of-life issues or hospice care, should don a surgical or procedure mask before receiving the visitor. This visitor should be reminded to maintain social distancing during their visit and should have received instruction on how to perform hand hygiene correctly by washing their hands and applying hand sanitizer following the visit. And we'll go over the sequence of hand hygiene sometime during this presentation. Where use of N95 respirator mask is necessitated by required procedure, nursing homes can help to conserve these respirators by limiting the number of staff who will be performing these high-risk procedures. And we'll talk about that, of when we could use the N95 or limit the use of N95. So let's talk about if and when there are confirmed cases of COVID-19 in your nursing home or adult care facility. Of course, you need to notify the local health department. For nursing home, they should be actively monitoring all residents on affected unit once per shift, including symptom check, vital signs, listening to lung sounds, and pulse oximetry. Assure that all residents within the affected units. This is when there's already a case of confirmed cases of COVID-19 in those units remain in their rooms. Of course, just like what we always do when we have a flu outbreak in our facility, we cancel group activities and communal dining. We offer other activities for residents in their rooms to the extent possible, and as I spoke to earlier. Residents must use and wear face masks when the healthcare personnel or other direct care providers enter their rooms, unless it is not tolerable by the resident. The resident must wear the face mask as the healthcare personnel enter their rooms. The other suggestion is to not float staff between units. I know this is difficult, especially now. We must make an attempt to not float staff between units. So we need to provide consistent assignment in as much as possible. It helps the staff coordinate the care, as we mentioned about bundling care. The cohorted residents with COVID-19 should have dedicated healthcare personnel and other direct care providers. We should minimize the number of healthcare personnel in entering the resident rooms. This is a continuation of when your facility has confirmed cases. In nursing home, all residents on affected units should be placed on droplet and contact precautions, regardless of the presence of symptoms and regardless of their COVID-19 status. Healthcare personnel and other direct care providers should wear gowns, gloves, eye protection. The eye protection include goggles or face shield, and N95 or equivalent, only if you have a respiratory program, because N95 requires fit testing for those staff with a respiratory program. Ventilator units require N95 with fit tested N95. Otherwise, healthcare personnel and other direct care providers should wear gown, gloves, eye protection, and face mask. The facilities may implement extended use of eye protection and face masks when moving from resident to resident. This is what we mean by extended use of PPE, but only for eye protection and face masks when moving from resident to resident. So what this means is do not change between residents unless other medical conditions which necessitated droplet precautions are present. However, gloves and gowns must be changed and hand hygiene must be performed. So at this moment, extended use of eye protection and face mask for when moving from resident to resident. There is no need to change between residents unless there are other existing medical conditions. For residents who initially test negative, retesting should be performed immediately if they develop symptoms consistent with COVID-19. So what do we do if there are suspected cases of COVID-19 in the nursing home? Residents suspected of infection with COVID-19 should be given a face mask to wear. And the facility must immediately contact the New York State Department of Health. The resident must be isolated in a separate room with the door closed. Staff who is attending the patient, if and until they are transferred, should wear gowns, gloves, eye protection, and face mask, and should maintain social distancing for at least 6 feet from the resident, except for brief and necessary interaction. Again, facilities should bundle care and minimize the number of healthcare personnel staff who enter these rooms to reduce the number of personnel requiring face masks. So the New York City Department of Health sent an alert number 6 dated March 15th regarding COVID-19 updates. First is to define what is COVID-19-like illness. COVID-19-like illness is described as a new onset of subjective or measured temperature of greater than or equal to 100.4 degree Fahrenheit, or cough, or shortness of breath, or sore throat that cannot be attributed to an underlying or previously recognized condition. So we need to separate this from the pre-existing condition, and this has to be a new onset of these symptoms. So let's define what a confirmed case of COVID-19 is. A confirmed case of COVID-19 is a COVID-19-like illness and a positive laboratory test. A possible case of COVID-19 is defined as a person with a COVID-19-like illness for whom testing was not performed. In children, however, fever with sore throat could also look like a condition of COVID-19, but it may be a strep throat. The parent or guardian should be instructed to consult the health provider to rule out other etiology. To date, factors associated with severe illness include people aged 50 years old or greater. Children and young adults at this time appear to be less affected, and the chronic medical conditions such as chronic lung disease, asthma, emphysema, hypertension, or diabetes are factors associated with the severe illness related to COVID-19. There are also infection control updates that need mention. A continuum of infection control measures should be implemented before the patient arrives. So there's gotta be a call or briefing between service line before the patient arrives. Upon arrival of the patient, throughout the patient's visit, and until the patient's room is cleaned and disinfected. It is very important to protect individuals at risk for adverse outcomes from COVID-19, and certainly those we discuss as older persons with comorbid conditions. Personnel who are performing triaging should have a supplies of face masks and tissues to provide to those patients with COVID-19-like illnesses upon their arrival. Putting a face mask over the mouth and the nose of the symptomatic patient can also prevent transmission of COVID-19 to others. So let's discuss the New York City Department of Health update regarding personal protective equipment. We mentioned this earlier. We are just wanting to let you know additional updates by the New York City Department of Health. As per newest CDC guidelines, patients can be managed with droplet precautions along with gown, gloves, and eye protection. This means that patients can be evaluated in private room with the door closed. If the private room is not readily available, ensure that the patient is not allowed to wait among other patients seeking care and keeping the distance of 6 feet or greater with easy access to respiratory hygiene supplies such as tissues and hand washing areas and hand sanitizer. The use of standard contact and droplet precautions with eye protection is appropriate when caring for patients with possible or confirmed COVID-19. PPE should include face mask and gown and gloves and eye protection. The AIIR, or the Airborne Infection Isolation Room, is no longer required unless the patient is undergoing an aerosol generating procedure. So what is that? An example of aerosol generating procedure are procedures such as intubation, suctioning, and nebulizer therapy. There's no longer a need for an isolation room unless those aerosol generating procedure is required with inpatient care. The New York City Department of Health recommends healthcare workers do not need to use a fit-tested N95 respirator or powered air purifying respirator, which are PAPR, for routine care of a COVID-19 patient. Supplies of PPE must be reserved for high-risk procedures because of the potentially restrained supply chain. Additionally, all healthcare workers are at some risk for exposure of COVID-19, whether in the workplace or in the community. So therefore, the New York City Department of Health is asking all healthcare personnel, regardless of whether they have a known exposure to COVID-19, to self-monitor by taking their temperature twice daily and assessing for COVID-19-like illnesses. Self-monitor by taking their own temperature twice daily. If healthcare personnel develop any signs or symptoms of COVID-19-like illness of 100.0, not 100.4, they should not report to work. The fever cutoff for healthcare personnel is 100.4. This is because we're trying to recognize the early detection of this illness. If any signs or symptoms occur while working, healthcare personnel should immediately leave the patient area and inform their supervisor per their facility protocol and isolate themselves from other people. So there are additional alerts from New York City Department of Health, Mental Health, with guidance for healthcare worker regarding self-monitoring and work restriction. Because there is a sustained widespread community transmission of COVID-19, healthcare workers currently furloughed because of previous guidance may now return to work if asymptomatic, no symptoms. They can return to work if they are asymptomatic. However, If they're sick, they need to stay home. So the guidance is if you have a new onset of fever, which is 100.0 Fahrenheit, or symptoms of possible COVID-19-like syndrome, such as a cough or shortness of breath or sore throat, you must stay home and immediately notify your supervisor. However, for mild illnesses consistent with COVID-19, healthcare workers must stay home 7 days following the onset of illness, or 72 hours after being consistently afebrile. Afebrile means no fever, without the use of antipyretics, Tylenol or aspirin, and with a resolving respiratory symptom, whichever is longer. The healthcare worker do not need to undergo quarantine or to have a negative test for COVID-19 to return to work. Let me pause there a little bit because this is a lot to absorb. So, if the healthcare worker has mild illness that might be consistent with COVID-19, they should stay home for 7 days following that onset of illness, or 72 hours after being consistently afebrile, and with resolving respiratory symptoms, whichever is longer. The healthcare worker does not have to undergo quarantine or to have a negative test for COVID-19 to return to work. If your symptoms are severe, such as difficulty breathing, and you feel that you need to see a healthcare provider, but it is not an emergency, you need to contact the healthcare provider before you seek care and alert them that you are a healthcare worker or a healthcare personnel who may have been exposed to a person with COVID-19. You should put a mask and ideally walk or take a private vehicle to travel to your healthcare provider. When arriving at the healthcare facility, let the staff know that you are ill and had a possible exposure to COVID-19. If an emergency, of course, you call 911, alert the operator that you may have been exposed to a person with COVID-19 and describe the symptoms. So how do we monitor our healthcare workers? All healthcare workers should self-monitor for illness consistent with COVID-19, because healthcare workers are at risk for unrecognized exposures. So what's the purpose of self-monitoring? This is to identify the illness early so that the healthcare worker could self-isolate or to reduce the potential of transmission to those you are caring for. The healthcare worker should self-monitor by taking your temperature twice daily and evaluating yourself for COVID-19-like illness, which includes measured temperature of 100.4 or subjective fever, a cough, shortness of breath, or sore throat. Notice the temperature is less than the required 100.4 for the definition for this purpose of the fever. For the healthcare worker, it's 100.0. This is because we wanted to recognize the illness early. The timing of these checks should be 8 hours apart, with one check immediately before each shift. So there's going to be a lot of temperature checking during change of shift. If any of these signs and symptoms develop, then do not come to work. If symptoms develop at work, you should immediately leave the patient area, self-isolate, and notify your supervisor. Healthcare worker with high-risk exposure to a confirmed or possible COVID-19 patient. If you are a healthcare worker who has had a known high-risk exposure to a patient with confirmed COVID-19, you should take extra care to monitor your health, but can keep working. There is no requirement for 14-day quarantine of healthcare workers with high-risk exposures in setting of sustained community transmission as we have in New York City. What are high-risk exposures? High-risk exposures include an unmasked provider having prolonged close contact with an unmasked confirmed COVID-19 patient. This high-risk exposure also includes a provider not wearing eye protection while performing aerosol-generating procedure, such as CPR, intubation, extubation, bronchoscopy, nebulizer therapy, and sputum injection. High-risk exposure also include an unmasked provider present for an aerosol generating procedure. The DOH asks that you self-monitor at least twice daily for symptoms listed above, such as fever of temperature greater than 100.0, or cough, or shortness of breath, or sore throat, and additional new onset lower acuity symptoms that may be associated with early signs of infection, which includes muscle aches or malaise, feeling tired or run down, or runny nose, or stuffiness, or congestion. So there's a responsibility to self-monitor at least twice daily for symptoms that I just mentioned. There's also an updated specimen collection guidance for COVID-19. The summary for this includes COVID-19 community transmission has been detected, and that's now new. That's not new to, and it includes New York State. COVID-19 testing is available in the New York State Wadsworth Center and in the New York City Public Health Laboratory and selected clinical laboratories. If any suspect COVID-19 cases, ensure that appropriate infection control precautions and immediately notify infection control lead at your facility and local department. Collect a nasopharyngeal swab for initial diagnostic testing for COVID-19. So let's talk about that. The COVID-19 specimen collection and handling. Collect nasopharyngeal swab for the initial diagnostic testing for COVID-19, which is placed in a viral transport media, VTM vial. So the oropharyngeal swab and sputum are no longer recommended for initial testing. The initial testing is using the nasopharyngeal swab for initial testing. If the initial testing is not conclusive, a sputum or lower respiratory specimen such as bronchial alveolar lavage or BAL or tracheal aspirate testing may be considered. Collection of sputum should only be done for those patients with productive cough. So induction of sputum is not recommended. And for testing of clinical laboratory, we must follow laboratory guidance for specimen collection, handling, and transport. Further testing at the Wadsworth Center guidance can be found at the New York State Department of Health COVID-19 healthcare provider website below. So there's also a new mandate reporting requirement, which is not new. We do this for the flu outbreak of COVID. For this one is for COVID-19 HERD survey. HERDs mean Health Electronic Response Data System. It needs to be done 7 days a week and needs to be completed daily by 1 p.m. So someone in your facility is designated to complete this. And this is the items and the data that needs to be collected daily, 7 days a week. The total in-house resident census, the number of lab confirmed COVID-19 cases, the number of COVID-19 suspected cases, the number of residents tested for COVID-19 with negative results, and the number of mask supplies on hand and needed on a daily basis based on current staffing. And does the facility have sufficient hand sanitizer supply for the next 7 days? And have we made requests to local OEM for supplies like thermometers, because now you're monitoring the healthcare personnel as well, twice daily, the gowns, and other PPEs. So let's review again the personal protective equipment. Employers should select appropriate PPE and provide it to healthcare personnel according to the OSHA PPE standard. The healthcare personnel should receive training and demonstrate an understanding of when to use this PPE, what PPE is necessary, how to properly don and use and doff PPE in a manner to prevent self-contamination, how to properly dispose of or disinfect and maintain PPE, and the limitations of PPE. The PPE is, of course, only as good and as effective if it is used correctly by the healthcare personnel. Any reusable PPE must be properly cleaned, decontaminated, and maintained after and between uses. There should be policies describing the recommended sequence for safety, donning, and doffing of PPE. We'll talk about that in detail later on. So this is the WHO guideline for hand hygiene. This one is very good because it's simple, direct, instructive, and easily followed by the healthcare personnel. So let me review this because we do not do this well. And this is something we have control of. So let me review the sequence and the steps for hand washing according to WHO. The scrubbing time is 20 seconds, but the duration of the entire procedure may take 40 to 60 seconds. The 20 seconds starts from step 2 to step 7. So step 1 is not included in the scrubbing time, which is turning on the sink and wetting the hands and applying enough soap to cover hand surfaces. Step 2, rub hands palm to palm. Step 3, right palm over the back of your hand with interlaced fingers and vice versa. Step 4, palm to palm with fingers interlaced. Step 5, back of fingers to opposing palms with fingers interlocked. 6, rotational rubbing of left hand clasp with right palm and vice versa. Step 7, rotational rubbing backwards and forwards with clasped fingers of right hand with left palm and vice versa. That should have been more than 20 seconds. Step 6 is when you rinse your hands with water. Step 9, dry your hands thoroughly with paper towel. You could use the paper towel to turn off the faucet. It is also a good idea to use the paper towel as a barrier to open the door in the bathroom. So the duration of this procedure may take 60 seconds. The scrubbing time needs to be consistent to be 20 seconds or more, at least 20 seconds. So the steps for the hand rub is the same. However, using the correct hand sanitizer, which would have to be 60% alcohol, the scrubbing time is the same. Just because we're using hand sanitizer doesn't mean the duration is less. So let's go through the steps. Being mindful that the scrubbing time duration must be 20 seconds. The entire procedure can take longer than that. And the scrubbing time starts from step 2 and ends at step 7. And that requires 20 seconds. Step 1, applying a poundful of product in cupped hands, enough to cover all surfaces. Rub hands palm to palm, right palm over left dorsum with interlaced fingers and vice versa, palm to palm with fingers interlaced, backs of fingers to opposing palm with fingers interlocked, rotational rubbing of left thumb clasped in right palm and vice versa, rotational rubbing backwards and forwards with clasped hands of right hand in palm and vice versa. Once dry, your hands are safe. The duration is 20 seconds, whether you're hand washing with soap and water or hand sanitizing with alcohol-based hand rub. So let me review the PPE per item.
Leah, hi, it's Effie. I don't mean to interrupt. Can you hear me?
Yes.
Okay, we have a few minutes, and I know we wanted to leave some time for some questions and clarification. So if we can move quickly through the PPE, I know there's some demonstrations available that people can review on their own.
Yes.
We'll be sharing the slides, maybe just to go over the highly relevant points in the next few slides so that we have enough time for Q&A.
Great, got it. Okay, thank you. So let me review some items just to be mindful of time for questions. So the PPE is very important to make sure that we use the right PPE and use it correctly, because it's only as good as its user. So with regard to the face mask or respirator, the face mask is recommended for routine care, except when performing aerosol generating procedure or in a facility with a respiratory program. For eye protection, such as goggles and disposable face shield, we may use them as part of the extended wear so that we conserve the use of goggles and face mask. Hand hygiene, of course, is very important, which includes hand washing or alcohol hand-based rub, and we could use the WHO or the CDC requirement. And the healthcare personnel should perform the hand hygiene for all those steps that's I've itemized here on letter D. These are the personal protective equipment use and how to safely don, use, and remove PPE. And PPE is defined as specialized clothing or equipment worn by an employee to protect themselves against infectious materials. This is the CDC guide for PPE. And I just want to itemize some key points about PPE. Don before contact with patient, use carefully and do the steps and sequence correctly so that not to spread contamination. Remove and discard carefully either at the doorway or immediately outside the patient room. Immediately perform hand hygiene. Clean the areas of where your PPE is stored or easily accessible. And ensure that hand hygiene products are readily available and accessible to point of use. This is the sequence of the PPE for donning and doffing. The sequence is important to minimize cross-contamination and definitely perform hand hygiene before donning and after removal of the PPE. And here's the sequence of the putting on and donning the PPE. And here's the sequence of doffing of PPE. So to wrap this up, so to make time for questions, PPE use in healthcare settings is definitely something we all have control of and is a take-home message of this webinar. PPE is available to protect you from exposure to infectious agents as long as you appropriately use PPE. Know what type of PPE, conserve PPE, use it wisely, and PPE is necessary for the duties you performed and use it correctly. And here are our references, and Effie will chime in to give us some of your questions, and Carmen will chime in to respond to some of your questions at this time. Thank you very much.
Thank you, Leah. Thank you so much for taking us through what is very many as a hello?
Yes,
Hello?
I'm in here.
Oh, hi, Carmentina. Hi, this is Effie Battis. Okay, can
Hi,
can
Effie.
everyone hear us? Yes? Okay. All right, great. Thank you. Thank you, Leah, for taking us through what's, you know, a lot of detailed information that's changing. I'd like to spend some time. First of all, thank you, Leah, and thank you, Carmentina, for going through all of this. We'll be sharing the PowerPoint slides. This is also intended for your staff to be able to share and obviously promote further education within your facilities. So some of the questions, let's start with, I think we elaborated on this, but maybe we need to clarify. Staff member has a cough, but has not had contact with someone with a virus. Are we to discourage them from coming to work? I believe that was addressed, but can we restate what would be the protocol for that? I understand it was to continue to monitor the temperature, but what if we do if there's just a cough? What should the facility do?
Right. The current guidance from New York State or New York City Department of Health is that when the person is ill, actively showing respiratory symptoms of cough or shortness of breath or sore throat or fever, and they also added GI symptoms of diarrhea, they should not be coming to work. But if we are talking of simple or cold symptoms due to seasonal allergies and things like that, there is no restriction for them to come to work, and just be extra vigilant in practicing respiratory hygiene or cough etiquette, which is, you know, when we cough, when we sneeze, don't use hands, but use the elbow or upper sleeve or a tissue, and trash that used tissue right away to the garbage, and of course perform the hand hygiene procedure as often as we could. Yeah.
Okay. Next question. CDC does not recommend face masks for healthcare personnel, yet we are required to wear them. I'm
Yes, yes, Effie. The mandate of New York State healthcare workers' use of face masks happened recently, I believe, last week of March 13th, when Governor Cuomo mandated us to use a face mask because of our increasing widespread cases of COVID-19 in the community. We follow what our local health department recommend, you know, and they supersede the recommendation of CDC.
okay. All right. Next is okay. COVID-19 residents should wear masks, or all residents if there is COVID-19 present?
Correct. As part of post-exposure management, all residents must wear face masks when the healthcare workers enters their rooms, only when it is tolerable, though, as Leah mentioned in the slide.
They're asking, though, if all the residents should be wearing masks as well, if there's COVID-19 present.
Yes.
Yes.
New York State guidance is that New York State Department of Health guidance is that upon entering of rooms by the healthcare workers, then the residents in those rooms, in that room, must be wearing face masks. But when the healthcare worker is not around, then there is no need to apply face mask on the residents. Is that
All right, next question. Why do we have to use droplet and contact precautions on all residents on affected floors? We do not have enough supplies to manage this.
Everyone is aware that the shortage of supply is happening, nationwide. However, when there is a clear transmission of COVID-19 that had occurred, as per New York State Department of Health guideline, is we treat everyone in that affected unit as if they have COVID-19. So in addition to standard contact and plus droplet, plus the eye protection of either use of face shield or eye goggle must be implemented and practiced in order to prevent further transmission or to contain, the COVID-19 virus that already had appeared.
Okay. Next question. I think we addressed this too. An employee has been exposed to COVID-19 but is asymptomatic. What's the precautionary measure for that employee?
Yes, I think Leah covered that very well in one of the slides. Right now, the recent guidance, and it just came up this week. There is no need to quarantine for 14 days. To those, we group the staff into two. Staff that were exposed and asymptomatic or not having any symptoms can go back to work and self-monitor themselves for fever and respiratory symptoms at least 2 times a day. And if they happen to, to get ill while at work, they must isolate at home. They must stop work, go home, isolate at home, and recommendation is 7 days from the resolution of symptoms and resolution of fever at least of 72 hours without use of antipyretic meds like Tylenol or Motrin. And those who are symptomatic and exposed, it's the same guidance that I just enumerated. Stay home, isolate for 7 days, and self-monitor for at least 2 times a day, check for fever and respiratory symptoms.
Okay.
Of course, I'm sorry, Effie. I I forgot to add that they must also seek medical care with their primary care physician and, follow their facility protocol in clearing the sick employee before they can return to work.
Okay. Is 100.0 a New York City rule or a CMS CDC rule?
It is our local health department rule.
Okay.
For residents, they have guided us to define fever as 100.4, but for employees, so we can catch initial onset of illness symptoms, it's 100.
That's
It's
for New York
our
City.
New York State, Department
Okay.
of Health, which followed by New York City Department of Health.
Okay. Is exposure to saliva when feeding COVID-19 patients considered close contact? I think the answer
Keep in
is
mind,
yes.
yes, Leah also covered, has a couple of slides talking about how is this COVID-19 being transmitted. Right now, from what we know of this disease, this is primarily spread from person to person through droplet transmission, which meant to say a person who is sick with COVID-19 coughs it out, sneezes it out to other persons mucous lining of the nose, mouth, and eyes, and within a close distance of 6 feet or less.
Mm-hmm. Okay. Given
That's
the
how
shortage,
close contact.
right.
I'm sorry.
Next question. Oh, no, I'm sorry. I'm rushing ahead. Given, given the shortage of masks, we want to have masks reused if not soiled or wet.
There
What are
is
the
a clear, yes, there is a clear written guidance from New York State Department of Health. I think it's in one of the alerts that Leah had in the slides, that the changing of mask is said to be whenever it is soiled or wet and whenever they go on break.
Okay. All right. Next question. For patients that do not have a sputum and have an inconclusive result from the nasal swabs, which other tests can be done in place of a lavage?
What the recent guidance from New York City Department of Health is nasopharyngeal swab. It must be done for initial diagnostic testing. Oropharyngeal and sputum are no longer recommended. However, from that question, it sounded like the nasopharyngeal already was performed and inconclusive. In this case, it is best to reach out to their local health department and get guidance on what is the next, specimen testing to be done or collected.
Mm-hmm. Okay. And then someone had a clarification comment. CDC recommends to do RSV swab first prior to COVID-19 testing. No need to get approval from DOH to test?
Yes, there are many commercial lab places now to perform COVID-19 tests. However, what CDC and our local health departments had been recommending us to do is think of other differential diagnosis first before you could think of COVID-19. Work them up first for other type of infections like flu, more so this time that the flu activity is still, elevated. And also work them up for other respiratory infections or other, infections like UTI before they could work the resident for COVID-19. If those workups came back negative, then what they said is that the time to subject the resident for COVID-19 test.
Okay. Thank you. If a person doesn't have a cough, can we do an oral rather than nasal swab to test?
As I mentioned, right now, the recent recommendation from local health department is nasopharyngeal swab is what is recommended. Oropharyngeal and sputum are no longer necessary.
Okay. All right, and someone commented you can look at CMS guidelines for nursing homes for a lot of this. That is correct, but we are trying to uh, present the information and support those who have additional questions. We're beginning to get calls, this is very important, from our local hospitals asking if we are taking new patients with confirmed cases of COVID-19. Can someone speak on that?
Yes, Effie. Actually, the directive from our local health departments is we can now care, many nursing homes can now care for COVID-19 confirmed cases as long as they are manageable in our facility, which meant to say many of them are showing mild symptoms. And those cases can just be, cared in our nursing homes because they want to reserve these beds, these acute beds, for a more severely ill COVID-19 cases. So that's why it is very important that the policies and procedures, for managing cases of this disease must have been in place from day one.
Okay. What is the longest extended time that masks can be used?
Are we speaking of our mandated healthcare workers' face mask use or
Yes.
the isolation? Yeah. Until we get the guidance from our local health department. Right now, we are mandated to wear face masks from Governor Como's office mandate. Yeah.
I think the question is, when they say extended time, they mean that they can actually wear the mask. Yes.
Oh, okay. Yeah,
How
I'm
long
sorry,
can
I
the
did.
same mask? No, it's fine. How long can the same mask be worn?
Yes, as Leah addressed it in the slide, extended use of mask is defined as we do not need to change masks from patient to patient, from resident to resident. However, when that particular resident has other medical conditions where it necessitates a droplet precautions, let's say that resident happen to have suspicion of flu, like illness or a confirmed flu, the mask must be replaced together with the gown and gloves right after use, right after each care, which is a routine protocol for our proper sequencing or using of PPE. However, if there are no cases like that, then mask can be worn. Again, go back to the guidance of whenever it is soiled or wet, and as per guidance of New York State Department of Health is when they go on breaks.
Okay, thank you. All right, gowns and goggles on affected floors. Is there a recommendation for facilities that do not have supplies to manage this?
It is very important to comply to the recommended isolation placement of contact, plus which is a mandatory use of gown and gloves, droplet, which is the mandatory use of face mask, and plus eye protection, which is a mandatory use of either face shield or goggles. There should be no compromise of that to, again, for the safety of the residents and the staff who are in that room. And if they are having problem with shortage, they can reach out to their local office of emergency management and get help for that matter.
Mm-hmm. And also your associations are, I know, all of the long-term care associations are submitting requests to either a city DOH or county or state DOH. So please continue to rely on your associations for that support.
Yes, thank you for mentioning that, Effie. As Leah had mentioned in the slide, we are now mandated to report to HERDS. COVID-19 daily report must be submitted no later than 1 p.m., 7 days a week. And a couple of those questions are asking for number of mask supply, and I believe is do we have a shortage? So that that will also reflect the whoever facilities have problem with this supply shortage. That should be reflected in their daily herd
correct.
reporting, mandated reporting. Yes.
This is another question. Are there any restrictions on not being able to accept gifts or snacks from families of residents in lieu of visiting?
What I can say with that is follow their facility protocol in accepting, items from a resident, but as a general rule, again, the transmission of this COVID-19 is through person to person, face to face, close contact within 6 feet, droplet transmission of coughing, sneezing to their faces, or whenever we touch respiratory secretions from this ill person. And then touching next our face, eyes, nose, and mouth. Accepting gifts or things like that, we can follow our routine, simple, common sense infection control practices of good hand hygiene, and cleaning and disinfection if there's a need.
Right. Okay. So we have 2 more important questions. Can you discharge residents with COVID-19 to their home?
Again, what the guidance, New York State Department of Health guidance is, yes, however, they must be in the picture. We must get their recommendation on discharging a resident with COVID-19 to the community. And we follow what the our local Department of Health will tell us on what to do.
Okay. And so we have another question. Are there specific criteria for admissions into nursing homes of COVID positive hospital patients?
Right now, yes. The
Okay.
criteria for person under investigations are well written, well said in CDC's website, New York State, and New York City DOH website. The policies and procedures in screening, a person who comes into our facility must have been in place, and there is a criteria to go by. And right now, it's all those fever or respiratory symptoms plus close contact with a lab confirmed COVID-19 or a healthcare worker who took care of that case. Second one is fever and respiratory symptoms plus travel from those affected geographic areas. And the third criteria is fever or acute respiratory distress syndrome without alternative diagnosis. So follow what are out there and put it into policy and procedure. And every person who enters the same way we screen our visitors, we screen our staff, is the same way we will be screening there should be a screening process for our patients more so, or residents,
Okay. All right. Thank you. That before we conclude, I just wanted to say 2 things. One, again, questions about the PowerPoint. We will be sending that out to all participants who registered. Second, we will have available for usage and sharing videos that we are creating related to the donning and doffing of personal protective equipment. We'll be sharing that with everyone. Feel free to share it with your staff. Use it as a resource and training tool. It is supported by the Department of Health, so we will make that available to you as well. We also will have another call, most likely next week at this time, to continue with guidance on any other developments we feel will change over the course of the next week. So we'll issues, concerns, and comments. And so I would encourage anyone that got this registration, there's a link to our staff. Feel free to reach out with your questions if you're not getting clear guidance or need clarification. and let us try to assist you with clarifying some of this in this obviously very difficult, unprecedented circumstances. So thank you to all of you for joining us. I hope everyone again stays safe and healthy, and we'll speak again. And please, as we said, feel free to reach out to us as needed. Thank you. Bye-bye.